When you think over 90% of women get dry vagina, get pain with intercourse, get all of those complications of GSM, and nobody talks about it.
Welcome to Thriving in Menopause, brought to you by Prevention Magazine. I'm Zoe Mernier, the editor of Prevention. Thank you for joining me for episode 2 of season 10. Today on the podcast, we'll be exploring a topic that is always very popular amongst our listeners, and that's looking at how we can continue or get back to enjoying a healthy sex life during this period. Obviously, much has been said in the past about how women's libidos can take a deep dive during menopause, but there are also many other symptoms that can impact our ability to enjoy intimacy as we have in the past. To talk us through some of these, as well as some of the treatments that might be available, we are pleased to be joined today by Dr. Judy Craig, a GP and cosmetic physician. Dr. Craig, thanks so much for joining us today.
It's an absolute pleasure.
Okay, so perhaps you could start by talking us through some of the menopausal symptoms that can get in the way of women having an enjoyable sex life.
The symptoms of menopause are actually very, very complex when it comes to its impact on your sex life. There's the general effects of menopause on your brain, on your tissues in your body in general, on your sleep quality. All of those things can definitely impact your libido and your enjoyment of intercourse. But of course, the ones that we focus on particularly are the effects on the intimate area. So we used to just call that vaginal atrophy and then list a number of symptoms. About 10 years ago, they grouped them all together and called them Genitourinary Syndrome of Menopause, GSM. And since then, there's been research into this field, which is it's very minimal still. When we look at how much research is done and the research budget in biopharm, for non-cancerous conditions, it's 1% of the research budget on women's health issues. In biotech, it's only 2% of the research budget on women's health issues. So it's not surprising. Very little has been done. There's very little talk of it in the media, which is why I'm so excited to be able to talk to you today and talk through some of the issues.
So under that banner of GSM, what are some of those ways that it manifests?
Probably the one that impacts mostly is vaginal dryness. And with GSM, with vaginal dryness, it's over 90% of women will experience vaginal dryness through their life, and 86% have vaginal dryness that is significant within 5 years of menopause. But menopause all these symptoms actually start with premenopause, which can start at about the age of 35, which surprises a lot of women.
Yes.
And that can sort of manifest and increase. But particularly once periods have stopped, then I think it's about 65% within a year have vaginal dryness. Now, when you also get atrophy, so the vaginal lining becomes thinner, so it can be prone to tearing and you can get bleeding during intercourse, and of course that's rather painful as well. Absolutely. So painful intercourse is a big factor. And with the atrophy of the lining of the vagina, you lose the glycogen in the surface cells, so you lose mucus. The pH of the vagina changes, it goes up, so it goes from being acidic to alkaline. You get different bacteria populating the vagina, so it becomes a more unhealthy environment. Now, it's not an infection as such. It's a bit like your gut microbiome. Your microbiome in your vagina changes. And with that, you get the pain with intercourse, which is a huge deterrent to enjoying a sex life. With the atrophy, you can get some muscle tightness, but you often get laxity of the vaginal walls, and you can get cystocele where the bladder bulges into the vagina, and erectocele where the rectal mucosa bulges into the vagina. And then you can go on to have prolapse and all of those sorts of problems which interfere with sexual enjoyment. But a lot of it is related to the dryness, lack of lubrication, and then pain with entry and pain with the friction of intercourse, and also the actual capacity of the vagina shrinks over time. And one of the sort of protective factors is actually having regular sex.
Right.
But of course, if it's painful, women aren't that keen on having regular sex.
Absolutely. What about things like, I guess, incontinence? Is that sort of something that tends to happen at this stage too, that could also be a pretty big deterrent, I guess?
That can be a major factor. Now, with incontinence, 1 in 3 women will become incontinent throughout their lifetime at some point. 50% of women who are incontinent are less than 50 years of age.
Right.
So incontinence is a major issue, and incontinence during intercourse is devastating.
Yes, absolutely. And when it comes to actually orgasm, that can be impacted. Is that sort of a separate thing? Is it because it's painful that your ability to, or the amount of time it might take you to orgasm is longer or more difficult, or is that actually a specific thing as well?
It's actually a specific thing, but it's actually one of those complex issues as well. If you're not in a happy relationship, you're less likely to relax and enjoy it. As they say, foreplay actually lasts all day. So if it's a happy day and you're being treated well, you're more likely to relax and you're more likely to orgasm more easily. Also, if intercourse is painful, you're not going to relax, and it's going to be overriding the natural process of the orgasmic process, because it's sort of, you have to build up to orgasm. But it all does actually slow down from a chemical perspective as well.
Right.
And you've got estrogen receptors in all of that area, and if you're not got those estrogen receptors stimulated, you're not going to respond as quickly or as effectively. So you often find that it's slow to enjoy and delayed orgasm, and also a less intense orgasm is not uncommon.
Right. Oh, well, that paints a rosy picture, really, doesn't it? So, I mean, I know at this stage of our lives we do, for very good reason, attribute many of our symptoms to the changes of menopause. But just to give a paint the whole picture, are there other non-menopause related conditions that women could be experiencing that could also be causing painful sex for them?
Oh, definitely, yes. So with intercourse, anything that's occurring within the pelvic area can be a cause of pain. So if you get, sometimes just deep penetration can cause pain, and particularly if it's pressing on the cervix. If you have a retroverted uterus, that's where the body of the uterus tilts backwards, can sometimes cause pain for women. You can have infections around the bowel. You can have ovarian cysts, but probably one of the more common ones is endometriosis, which affects at least 1 in 10 women, but it's probably a lot more than that because it's really underdiagnosed. And then, of course, any ovarian issues, if you've got an ovarian cyst, if you've got ectopic pregnancy, if anyone develops sudden acute pain with intercourse, they really need to get seen to quickly to see what's going on. And any infection in the fallopian tubes or in the pelvic area, bladder infections, can all cause pain with intercourse. And then you get joint problems as well. If you've got back problems, hip problems, and you can get referred pain to the vulva vaginal area. You can get a thing called vulvodynia, where the nerves are overactive and cause pain. And then there's women who suffer from lichen sclerosis, which is a white sclerosing condition of the vulva on the outside. And it actually scars up the external area and scars the opening to the vagina and to the urethra and around the clitoris. So it's a really disabling condition, and there are treatments for it, but that, of course, can produce severe pain with intercourse because the tissues don't stretch, so you get tearing.
I mean, I think, what I'm really sensing here is that absolutely medical help is kind of essential to whether you think it's from menopause, whether it's something else. Getting checked out is essential, and I think it's something that I imagine many women aren't seeking help for a lot of these symptoms. Am I right?
Absolutely. I had a function at the clinic, and it was for cosmetic treatments, of the face and maybe some body changes and things. And I had 30 women attend. And I actually spoke about incontinence, which none of them were expecting. And I actually shared some of my own experiences. Having spoken about it, there was a lot of chatter after I finished the talk. And one of the ladies who's been seeing me for many years came up and said, Judy, I just spoke to 12 women in a row. Every single one of them said they had incontinence, and not one of them had ever told a friend or a GP or sought any help. And really, that's the bottom line, and that's the situation. And if we think that's bad, when you think over 90% of women get dry vagina, get pain with intercourse, get all of those complications of GSM, and nobody talks about it.
Yeah. And I mean, I think perhaps a lot of women just don't think that there's much that can be done. So let's put a positive spin on this and let's talk through some of the treatment options that are available for women suffering from these problems.
Yes. So just one other quick thing I'd like to say is with menopause, the symptoms like hot flushes resolve over time in the majority of women. Genitourinary Syndrome of Menopause doesn't. It just progressively gets more severe, right, unless it's actually treated. And that's a big problem for women. And I've read articles even recently, and women often get this from when they go to talk about it, if they do broach it with their GP even at times, that it's part of normal life. It's not that severe. Just brace yourself, you're fine. It's and get on with it, basically. But that doesn't have to be the case. And it impacts relationships, and that can lead to broken marriage or loneliness, and for women sometimes homelessness. I mean, it's tragic. It's all treatable. It's
no small thing, yeah.
Right. Sorry, now let's move on to positive things.
Yes. There is light at the end of the tunnel.
It is a very, very wonderful light at the end of the tunnel.
We'll be right back after this.
Perimenopause can actually start in your 40s. Declining estrogen production during perimenopause brings on changes to menstrual cycles and often the onset of hot flushes, night sweats, mood swings, and sexual problems. Promensal Peri is specifically designed for perimenopausal women and can help relieve these common menopausal symptoms. Promensal Peri is available at leading pharmacies across Australia and offers a cost-effective treatment at under $1 a day. When things start to change, try Promensal Peri. Always read the label and follow the directions for use.
Okay, we're back.
So how do we manage it?
Yes.
Hormone therapy can manage a lot of the problems and symptoms that we're talking about. The impaired brain function, it improves gut health, protects bones, improves skin. However, it doesn't fix the GSM, or the Genitourinary Syndrome of Menopause.
Yes.
Even though there's
did notice that missing from the list.
Yes, it was definitely missing from the list. I do believe, and I haven't got any studies or statistics to support this, that women who are on menopause hormone therapy from early on, say particularly pre-menopause period, and are sexually active, seem to have a delay in onset of the Genitourinary Syndrome of Menopause symptoms. Probably doesn't help enormously with some of the bladder, although there are estrogen receptors in the base of the bladder, in the urethra, in the sphincter, which is what you need to be functioning well to control your urine. And so estrogen can help when you're using it as a patch or a gel to some degree with that, but it's actually local treatments that are required. So then you're looking at whether you're using a topical cream or gel or pessary in the vagina, and certainly symptoms can improve with that. And it's a good thing to do on an ongoing basis, but women often find that it's a bit messy, they don't enjoy it that much. And it's something you have to do on a regular basis. In recent times, there's been other treatments available for women. The first one that came out was a laser. There's a Mona Lisa touch, probably some women have heard about. Yep. And that restructuring and help in the surface of the vagina can make quite a difference. Laser penetrates about 0.7 millimetres into the surface of the vagina. So it's got an applicator that goes into the vagina and can treat internally. And that can improve the symptoms of GSM. There is always a risk with laser of burning and scarring. More recently, people developed radiofrequency treatments. The initial ones didn't have a temperature feedback because radiofrequency works by heating the deep tissue, and with heat, you actually get a change in tissue structure, and rejuvenation stimulates the fibroblasts, which are the cells that produce collagen and elastin. So you improve the support and tissue thickness in the area. It stimulates the cells that produce blood vessels. So you get what we call neovascularization. So you get more blood vessels, more fibroblasts, more collagen and elastin. So the tissues all become healthier, and you get an increase in the glycogen-producing cells, and they produce mucus. So you get your lubrication back, you get thickening of the vaginal wall, and so things improve. Initially, the treatments didn't have a temperature feedback. It was just a smooth device that put radiofrequency energy through the walls of the vagina. And they got really significant changes. But there was always a risk that you could cause burns because you can't feel if it's hot. So it all came down to technique of how quickly you move the device to not get areas overheated. And, people... physicians became very good at doing that and making sure people were safe, but there is that risk. The device that I have this, so I have to declare that I do have an interest in it.
Yes.
And I love the device that I have available to me. So this is the Empower RF platform by InMode. The technology is amazing. So there's sort of 3 devices attached to the platform. And I've found that you can just transform a woman's life with this device. So there's a smooth applicator, which is very similar to the other one I described, but it has the central plate, has a real-time temperature feedback to the machine. And so you set what they call a cutoff temperature. You say, I want the tissues to go up to this temperature. And when it gets to that, don't want any more radiofrequency energy being transmitted into the tissue. And the machine cuts off and won't produce any more until the temperature's within the range. So you've got this really good safety mechanism, and it's comfortable. The only women that I need to prep for it are ones who are very dry and have a lot of pain with intercourse. So I usually give them 2 weeks of intravaginal estrogen, and at times I need to numb them as well.
Yeah.
Then we can do the treatment.
And with the Empower RF, is it usually a series of treatments that's required, or?
Yes. So normally we recommend a series of 3.
Yeah.
And then a maintenance of maybe 1 at 6 months, and then maybe even yearly after that. That's the Form of V is the one I was describing, which is the smooth one.
Yes. Then
there's the Morpheus 8V, and there's been some really interesting studies with Morpheus 8V. So a lot of the people listening will have heard of Morpheus treatment for the face and body, and it's very much the in thing for lifting jowls and changing the features of aging and treating aging necks, and it's very, very, very popular. So Morpheus 8V is like the Morpheus 8 on the face. It has needles. Even though it has needles, it's not painful. It's much, much more comfortable than the face.
Yes.
Penetrates, so you can treat the depth of 3 millimeters, 2 millimeters, and 1 millimeter. So you take the energy below the surface of the vagina into the deep tissues. And in doing that, you can take the temperatures much higher. And with doing that, you get a lot more structural change, which can help with incontinence. Well, both can help with incontinence, but this is much more effective, structurally change the tissues and resolve symptoms of the GSM and incontinence, improve sexual performance, improve the strength of an orgasm. I get very, very happy women coming back to see me.
Fantastic. Okay, so say a woman has been experiencing painful sex or a lack of libido for a while, and there can obviously be some trepidation about rekindling intimacy, and, it just feels easier not to go there. But what's your advice for helping women kind of ease back into things, maybe post-treatment?
That's a very, very good question, because there's often a gap. They're avoiding intimacy because they fear intimacy will lead to sexual intercourse, and they're avoiding that because it's been an unpleasant experience. So they tend to sit on opposite sides of the room, opposite ends of the couch. So my advice is to raise the topic, be open about it. And I know that can be really difficult, maybe over a glass of wine and a meal when you're feeling relaxed and comfortable, yes, to discuss that. And then enter into a sort of program of progressive contact. So even just sitting next to each other with your arms around each other, fully clothed, and say, okay, this is what we're going to do for the next 2 weeks. We're going to sit on the couch and watch something on the TV or just listen to some nice music and chat. Then move on to it being a body massage, but not a sexual one, and just have a nice time getting to know each other again and getting close. And that physical contact, we all need physical contact. That's one of the things that often is lacking here. And then and you might set aside a week or 2 weeks to be at that phase. And then with mutual agreement, then you move on to touching genitals and breasts, but no penetration. And that needs to be strict, and both need to stick to it, whether they want to or not, no matter how much the desire to move on to the next stage. And it has to be with trust and respect for each other. And you get the benefit from that program if you stick to it. And then when you get to the penetration stage, that's where it's really important that there's adequate lubrication, and there's nothing wrong with using lubricants if you're still feeling a bit dry, which is possible and just will make it actually easier anyway.
Yeah.
And there's a whole range of lubricants, and I recommend that people women go and try a variety of ones, because some are more comfortable than others, and some you use on a regular basis. Then when you actually move on to intercourse, that the woman controls the rate of entry. So an easy way to do that is to lie side by side, whether it's face-to-face, side-by-side, or spooning, but probably face-to-face is an easier one, or the woman on top. The only thing with being on top is you want good knees and
yes,
hips, and so it can be a bit, and arms, you need to hold yourself up. So if you've got some physical disabilities, that can be problematic, because then you want to change, you want to control how quickly the entry is. And if it's feeling a bit sore or tight, then you just stop for a while and then you try again. So even some finger penetration so that things relax, and a bit of foreplay is so important. Kissing, touching breasts, touching clitoris, and all of those areas. If you're not doing that beforehand, penetration can be a problem for a lot of women. But even with that, if you're really dry, but that's where using a lubricant can help. And then just moving gently onto the penetration. And when it gets deep, there's two things. One, you can ask the partner not to penetrate as deeply, or you can change position. So you may find it more comfortable side by side, you on top, in a spooning type position, whichever one works for you. So someone who's got a retroverted uterus may find it's easier in a spooning position. It's not as uncomfortable. It's really a matter of experimenting to find which one works, and that's mainly for pain with deep penetration. The pain on the outside with the friction or the entry, that's lubrication, relaxation, other things that will make a difference for that.
Oh, thank you. That's been so incredibly helpful. Unfortunately, that's all we have time for today. So, Dr. Judy Craig, thank you so much for joining us today.
It's a pleasure.
And listeners, thank you for joining us as well. If you liked this episode, we'd love you to rate, review and subscribe. And we hope you'll join us for next week's episode. Meanwhile, for more information about living your best life at midlife, pick up a copy of Prevention Magazine. I'm Zoe Mernier. See you next time.